Welcome to GEMcast, the Geriatric Emergency Medicine podcast, where we discuss important topics in the care of older patients in the emergency department. I'm your host, Christina Shenvi. GEMcast is produced with the Geriatric ED Collaborative. You can find more episodes on any podcasting app, and you can find the show notes on the resources page of gedcollaborative.com. Welcome back to GEMcast. I am joined today by a special guest who is not an emergency physician, but is a colorectal surgeon at UCLA. This is Marcia Russell. Marcia, thank you for being here today.
Thank you so much for having me, Christina. I'm excited to be here today.
And Dr. Russell has done a lot of work over the last 20 plus years engaging in making surgery safer and hospital stays safer for geriatric patients specifically. And what I want to talk with you today about, Marcia, is the new CMS Age-Friendly Health Measures. And these are a set of 5 domains that hospitals will have to initially just attest that they are doing, but then within a couple years, around 2027, I believe, they will be tied to CMS reimbursement. And these are 5 domains, all specific to geriatric care, but may take place in all different parts of the hospital. So not specific to surgery or EM or, internal medicine, but very important to geriatric care. And I think we're really seen as a big win for folks who do geriatric care and are promoting it. So I'm curious, Marcia, what was your involvement with them and what was the impetus for developing and putting these forward for CMS?
Well, Christina, I think the impetus for this was partly to just bring awareness about the vulnerabilities that older adults have in the hospital. And CMS really has always been a big stakeholder with our work. And, this is kind of the first step forward to put some, money and payment and incentives behind improving care for older adults. And, this is a really exciting first step, but it is just one in the journey of many moving forward. And I just want to highlight that this measure is really a collaboration amongst multiple organizations. So the American College of Surgeons played a role. We collaborated with the Institute for Healthcare Improvement, which has put forth the Age-Friendly Health Systems, and also the Geriatric Emergency Department Accreditation Program. And it really was these organizations, coming together and collaborating with CMS to put this age-friendly measure forward. I've been involved with the ACS for a long time through the Geriatric Surgery Verification Program, and it's been really, great to see the collaboration of these 3 organizations and this first step that highlights, where we could start improving care for older adults.
Thanks for that background. And yes, we are so often siloed, especially in our professional organizations. We have ACEP with our geriatric ED accreditation. We have, ACS with its geriatric surgery verification. And it's wonderful to see the groups working together along with other groups like the IHI. Well, let's dive into the 5 domains. And my goals for this session are just to introduce listeners to what they are, because all your hospitals are going to need to be attesting that they are doing, at least whether or not they are doing them. It won't be tied to reimbursement initially. So it's important for us to know what they are. And the first domain is called Eliciting Patient Healthcare Goals. Marcia, can you tell us a little bit about what this means and what hospitals will need to do?
So the healthcare goal domain has 2 main areas. So one is really understanding what's important to the patient. And, the IHI age-friendly component of that, they call what matters. So, really identifying what matters to the patient for their care at that, moment in time. Whether they're there for a surgical problem, medical problem in the emergency department, really sort of understanding what's important to that patient about their care and how that ties into their other goals. Is it how long they live? Is it the quality of their life? Is it making it to their daughter's wedding, which is next month? The goals can be very different for patients. And so this is one of those first steps to connect with the patient and understand what matters to them. The other prong of this is just making sure that the health system is aware of the patient's preferences as far as their code status, any other, life-sustaining preferences, and who their surrogate decision maker is. And despite having attention to these efforts over the years about advance directives and proxies, there are still patients that, don't have a proxy when they come into the emergency department, or their code status is not clear. And so this is just kind of one other touch point that when the patient is in the hospital, the other component of their goals piece is understanding their preferences around the code status, their surrogate decision maker, and any other, big picture care plans.
I like that you brought up the what matters most. And a lot of these domains that we're going to talk through are very influenced. You can hear the language of what was initially the 4 M's and then became the 5 M's. The initial 4 M's were mentation, medications, mobility, and what matters most. And then the 5th M is this idea of multimorbidity or many comorbidities and understanding how those influence each other. And the language that hospitals will need to attest to is that our hospital has programs in place to ensure patients' goals related to healthcare are obtained and reviewed and documented in the medical record. And it's updated before any major procedures or on significant changes in clinical status. So just from the ED perspective, for those who work in the ED, if somebody's coming in and now needs a major procedure or has a major change in their clinical status, that is a time when we might need to update their goals of care and understand their new living will, etc. The second domain is another one that's, a key geriatric principle, which is polypharmacy or medication management. And domain 2 is responsible medication management. So Marcia, what does that mean?
So responsible medication management in the older adult not only focuses just on the number of medications, so polypharmacy is really focusing on the number. And, I think it's more than 5 is what's truly considered polypharmacy, which, to be perfectly honest, pretty much every adult is on more than 5 medications. So they all have polypharmacy problems. And the goal is to make sure that the medications they're taking are appropriate for them. So looking for opportunities to deprescribe, are there 2 medications that are doing the same thing, and can we get them down to 1 medication? That is one component of medication management. The other component does revolve around this concern for patients getting delirium in the hospital, and that there are some potentially inappropriate medications for older adults that we know have an association, with delirium. And so looking for some of those medications that they may either be already on, and maybe we want to try to get them off. And then also during their hospital stay, trying not to give them some of those medications that we know are triggers for delirium. One simple one being, Benadryl or diphenhydramine, commonly given for sleep, commonly given for itching around patients receiving, opioids in the hospital. And, that one medication given to a 85-year-old could be the trigger that tips them over into a delirium episode, which will, really impact the trajectory of the rest of their hospital stay. So that's the other emphasis, I think, around the medication management for older adults is on this kind of delirium prevention piece. And also the last thing I would add is around dose adjustment. So we know that older adults have less muscle mass. They may have other morbidities that influence their ability to clear, certain medications. And so just being attentive to the dose of medications, using like opioids as an example, patient falls, they have surgery. There's a bunch of reasons patients get medicine, in the hospital for pain. And so starting them at a lower dose is more appropriate for older adults. So I wouldn't give the same dose of oxycodone to a 85-year-old that I might give to a 40-year-old. And so just being attention to the concept of dose is another component of this.
This one is so near and dear to my heart. I actually just got back from Houston, where I was speaking at the American College of Osteopathic Emergency Physicians annual meeting on delirium prevention and management, as well as as well as not exactly polypharmacy, but this concept of potentially inappropriate medications. And I want to give a really big just caution to anyone who is tasked with implementing, okay, now our hospital has to attest that we review medications, we identify potentially inappropriate meds, PIMS, they're called, and we have protocols for reducing them. Because one of the unintended consequences that has happened in many sites is they have indiscriminately created alerts, for example, for all medications that are on the Beers list. And this is hugely problematic. Like, I can't even overstate how problematic this is, because almost every medication that we use is potentially inappropriate for the correct patient and at the correct dose. However, it may be a very appropriate medication. As an example, aspirin is listed on the Beers list, and the Beers list, for those who aren't familiar, is a list of potentially inappropriate medications. It is potentially inappropriate as a means of primary prevention of cardiac disease. But if you come in with an acute MI, it is a highly appropriate medication. And in fact, I would be not following the standard of care if I did not give it to you. But when it flags as this is potentially inappropriate, that does two things. One, it causes a lot of confusion for clinicians who then are thinking, wait, this is an appropriate medication. Why am I getting this error or this alert? Second, it causes alarm fatigue, because if they are getting so many flags for medications that are appropriate, then you start to disregard those flags because 90% of the time they're actually incorrect. Another example is nitrofurantoin. That's on the Beers list, but only if you have a creatinine clearance of less than 30, because then it won't concentrate in the urine and won't work. And that's a medication that I love to use for our older patients with uncomplicated UTIs. So we need to approach this one in particular with some nuance and some intelligence and some deep understanding of the medications that are potentially inappropriate, and we cannot apply something like the Beers list indiscriminately. We need to be thinking, and I'll get off my soapbox soon, I promise, but this is one of my favorite soapboxes. We need to be thinking not just here's a list of potentially inappropriate medications. You have to be thinking about the drug-drug interactions, the drug-patient interactions, and the drug-disease interactions. And then I would add another component there, which is at the right dose. Like you mentioned, oxycodone may be a perfectly appropriate medication for a patient with an acute fracture, but not at 10 milligrams, maybe at 5 or at 2.5 even. So I'll step off my soapbox, but my real fear with this one is that hospitals will indiscriminately just plug in a flag for every Beers list medication, which is going, I 100% predict, to do more harm than good. What are your thoughts there?
I think those are all really important and valid points, Christina. And anyone that's looked at the Beers list, and if you haven't looked at it, it's a very long, laundry list of medications, and there is a lot of nuance to them. So I agree with you completely. Plugging them in and saying all of these need to get a best practice alert if they're prescribed, you're going to get 10 for one patient just admitting them to the hospital. And I think it's very different if a patient has been on a potentially inappropriate medication and they're tolerating it, it's their regimen, there's no side effects. That's a different situation than starting a new medication that might not be right for that patient at that moment in time. And so it is important to, I think, be thoughtful. And I think in the surgery space, we've looked at it more from a perspective of, here are 5 to 10 medications commonly prescribed in the perioperative space that are on the Beers list that you can focus your educational efforts, or automatic substitution for Benadryl for anyone 65 and above if you're ordering it for sleep, for example, and be thoughtful about it and be targeted about it, as opposed to this broad, these 500 meds are now all problematic.
Yes.
So I would definitely favor a more targeted approach to your environment or your specialty. There may be 5 medications that are really important in your specialty that are on this list that you want to target your education and your interventions around, as opposed to across the board, alert anytime it's ordered.
I like that idea, and I'm curious what your top five are. The ones that I do a lot of education around caution with are definitely diphenhydramine, although if they're coming in with an allergic reaction, sometimes you might need it, but often there are other options that have fewer side effects. The other is benzos. I really try to avoid benzos unless you're in acute alcohol withdrawal, in which case benzos are appropriate. And then having caution, especially with your typical antipsychotics, which can cause more side effects. So I'm curious what your top five are. But the other just caution with using the Beers list indiscriminately is most of those cautions are for longer term or outpatient management, which if you're in the ED or the immediate post-op or peri-op or ICU setting, it may not have the same risk.
Yeah, so there's definitely some overlap for the meds that I'm concerned about. So I think, Benadryl definitely is on my list, commonly given, as I mentioned, for itching around pain medication use and, given for sleep. Avoiding benzos, I think, partly for this post-op delirium piece. Like if your patient is getting agitated, giving them a benzo should not be the next, first step. Try to figure out why they're confused or agitated as opposed to treating them with the benzo. Appropriate dose of opioids, I think lower dosage, is another one we really focus on in surgery. There are some medications around post-op nausea and vomiting that are a little better, than others in this space for older adults. So that's one other area of attention. And use of NSAIDs. So NSAIDs are on the Beers list. However, for short-term use for pain control after surgery, especially in a patient with good, kidney function and creatinine clearance, I do think NSAIDs are an appropriate option. They may help you minimize the opioids, which are another medication on the Beers list. And so, you could see how there's this push and pull between these two pain medicines, NSAIDs and opiates. They're both on the Beers list, but you could make the argument that a little bit of NSAID to decrease the opiate use could be a positive thing. So once again, this nuance to the medications that you're paying attention to, and that they're tailored to your specialty or setting.
I love that. And I think, I don't know if there's a group already working on these domains of how do you actually implement it with, more implementation guides. But this is one that I think really needs a specialty specific implementation guide for the ICU, for the ED, for, the post-op setting, for the inpatient setting, because I worry about unintended consequences. All right, let's move on to domain 3, which is frailty screening and intervention. And this one, they actually brought in some M's of mobility, mentation, and malnutrition. Tell us more about this one.
So this domain on frailty screening is really meant to assess the older adult for any sort of geriatric vulnerabilities they may have in these domains. So, limited mobility, malnutrition, risk for delirium, for example. And if we know that they're vulnerable in a particular area, then the next step is, a management plan to address that vulnerability. And I want to be very clear that that management plan can be very different for different patients. It may involve something in their hospital care, like early involvement of physical therapy. It could be something more involved than that. So let's use nutrition as an example. If there's a very malnourished patient and you are getting them ready for a surgery, there may be some time to optimize them with supplements or, nutrition through the IV, for example, before surgery. That might be a more prolonged, intervention plan. If someone has very mild, malnutrition or a potential swallowing problem you pick up maybe the intervention is just part of your hospital stay. So early nutrition after surgery or involving speech pathology. You may be capitalizing on resources that you already have at your hospital, not necessarily this big prolonged, optimization plan, before an intervention. So, I think the cornerstone of this domain is really identifying the vulnerabilities. And then once you know them, being thoughtful about what does this information get you and how can it change how you care for that patient, potentially in the short term and also in the long term. So I think it's important that we do the screening, but we also need to use that information, in some meaningful way to, optimize the care for that patient.
Yes, and this domain has a larger amount of language around it, and hospitals will have to attest that they screen patients. And to your point, I love that they then say you use the screens to create management plans because you can have tons of screening and beautiful databases and dashboards, and then how does it actually help the patient? And then third, they have to collect data on rates of falls, decube ulcers, readmissions. And then fourth, and here's one that really is especially needs to be owned by the ED and the hospital flow program, is that hospitals have protocols to reduce the risk of ED delirium by reducing length of ED stay with the goal of transferring a targeted percentage of patients out of the ED within 8 hours of arrival or 3 hours of the admit decision. And this topic, I'm so glad that this was included because this gets at the problem of ED boarding, which is not an ED problem. It is a hospital problem. And I don't know if you saw, there was just an AHRQ roundtable on this a couple days ago that I was watching yesterday and talking about how boarding in the ED is not a problem with ED volume, ED efficiency, ED flow per se. It's a problem of there's no space inpatient, and so we can't get the patients upstairs. So I think that this one really has a huge potential for driving change, because if we need to get patients out of the ED within 8 hours of arrival, there are patients who stay in the ED boarding for up to 24 or 48 hours in many places. So I'm very excited about this one.
I totally agree on the ED boarding. That's really a throughput and a hospital level problem, not an isolated ED
Mhm.
problem. The ED can't fix the boarding problem alone without cooperation of other flow throughout the hospital. And I just wanted you mentioned the data collection piece, and I just wanted to mention that though the data that are recommended to collect falls, ulcers, readmission are things that the hospital is already collecting. And those measures were picked partly to not add extra burden to the
Mhm.
hospital. So I just want to be clear that this age-friendly measure is not asking you to collect additional data above and beyond what your hospital is already
Mhm.
doing for JCO and sort of other, regulatory agencies. But you can use that data to, inform your efforts around the screening and interventions as you work on, delirium, for example. It does all tie in, but it was not
Mhm.
meant to be a
Mhm.
heavy lift for the hospital.
That's nice that they put it in here, though, because then it's built into how do we use this data that we're collecting to then provide, feedback for our
Right.
PDSA cycle to continuously improve.
Definitely.
Domain 4 is another kind of broad one, which is social vulnerability. And they specifically list social isolation, economic insecurity, ageism, limited access to healthcare, caregiver stress, and elder abuse. And uh, this is kind of a larger set of topics that, often in med school, this wasn't part of traditional quote medicine, but now we realize, wait, this is the context in which medicine takes place. So tell us about this domain.
Yeah, I think the social vulnerability domain is a really important one. It may not be an area where a lot of hospitals are giving attention to, and maybe the one that is the heavier lift. But I think it's really important that we're bringing attention to these issues because the issues around social isolation, social support, having caregivers, they are so amplified in that older adult population. And when they come into the hospital for either an acute problem or an elective surgery, where they go after their hospital stay and what their care plan will look like is so influenced by the amount of support that they have or don't have at home. And I think the sooner we know some of this information about our socially vulnerable older adults, it really helps us come up for a better care plan for them. And so we're finding about it earlier in their care as opposed to they're ready to go home from the hospital and then we find out that, oh, we live alone and we don't have any friends or neighbors nearby. And it's like, well, if we knew that earlier, we would have had a different plan for you going into this. And so I think it's really great that we're bringing attention to some of these issues that we maybe haven't attended to as much in the past, but they really will help influence how we care for older adults and especially how I think we transition them out of the hospital.
Yes, and this also requires multidisciplinary collaborative care with our social workers, case managers, outpatient services to try to provide that support that may not live in the house of medicine. It may be, Meals on Wheels or
Right.
other, home services or local aging services, et cetera, that is very community specific.
Definitely.
And I want to put a brief plug for a paper that Tony Rosen, Elaine Gottesman, and myself just published. I think it's still listed as in press, so the full thing may not be out. But the title is The Importance of Addressing Social Drivers of Health and Unmet Social Needs in Optimizing Geriatric Emergency Care. So if you want to find one paper that will summarize a lot of these issues and opportunities and tools that will summarize the literature for you, I'll just put a brief plug in for that.
Perfect.
And then the final domain is age-friendly care leadership, in which hospitals will have to attest that they have an age-friendly champion or team or committee. And what's the goal with this one?
I think the goal with this one is you really have to have a leader or a point person to, make change in these other domains. I think that this was meant to be flexible, that in some smaller hospitals, for example, you may just have a champion, not a formal multidisciplinary committee. In a larger academic medical center, you probably potentially have a committee with multiple stakeholders and you will have your champion, leading that committee. But to really make change, you need to have everyone at the table. And we have pushed this in the geriatric surgery verification program as well. You have to have a champion of your program that is driving the vision, driving the quality improvement efforts. And without a champion or someone paying attention to this, it's really, I think, impossible to put these other domains into play. And I think some hospitals may have this person already in a role that is working on geriatric efforts. Other hospitals may need to identify a person and set up a committee. I think that how this is put into play will be very hospital specific, whether it's one person or a committee. But I do think it brings attention to we need someone in a leadership role to put these other domains of goals, medication, screening, and social vulnerability into play.
My concern with this one is I worry that potentially hospitals would put someone in place and that would meet the letter of the domain, but not the spirit of the domain, if they do not give that person then the adequate resources, positional power, or support to actually effect change. If they just name, okay, Christina, you're now our age-friendly champion, but I don't have any supported time, I don't have any ability to make change, I don't have positions on the right committees. So, what do you think for, say, a large academic system or large academic hospital? What would an effective age-friendly champion or committee involve?
Well, I think it would definitely be a committee that has, I think, a charge to address and put into play, the domains to meet the measure. Just naming a person or naming a committee that can't actually do anything in real life doesn't change anything. And so I think there has to be some emphasis on the communication strategies. So is this person reporting up to the quality person who's reporting to the CMO? There needs to be, I think, clear chain of command. The hospital needs to make the resources available to make this a priority. So if you want to build vulnerability screening into your admission order set for the nurses to ask 5 new questions, you can't put that into play without the support of, IT to build the questions in and get it into the record. And so it does really need to be a team approach with health system leadership to prioritize the age-friendly implementation to other resources like the EHR, building out templates, building order sets, whatever you need. I think that is a key component of this, that you do have some resources delegated to you. And I think the last is just that you have all the stakeholders at the table, because if we are going to be making changes and optimizing the care and we don't have everyone's input at the beginning, it's not going to be successful on the implementation side. And so trying to get everyone together at the beginning and having that age-friendly champion have their point people of the different stakeholders, I think is another key component of this to make it successful in the long term and not just a one-off attestation. We have someone, we have a point person.
That's a great point. And yes, if you want to make changes in your EMR, then you need a representative or stakeholder there. You need stakeholders from nursing, from outpatient care, from ED care, from inpatient care. If you're missing those pieces, then it's happened many times where no one from the ED is on the right committee. And then they roll out this change that when it gets to us, we say, no, this is never going to work here, or vice versa. So I like that point. This needs to be multidisciplinary, needs to have all the stakeholders, needs to be organized, needs to have the power to make changes, and needs to have a clear reporting structure. Well, thank you, Marcia, for providing that clarity and context on each of these measures. And these are, if you want to read more about them, I'll include a link to a PDF in the notes. Or you can find the CMS Inpatient Prospective Payment Systems document online. It's a brief 1,400 pages, I think. And this is around page, I forget, 1,200. So I'll include a link to a shorter version. But these are so important because these are going live. Hospitals will have to attest to them in 2025, and then it'll be linked to payment a couple of years after that. So we need to be thinking now about how do we thoughtfully implement them? How do we not accidentally do harm with how we implement them? And how do we do it in a way that works for nurses, works for physicians, works for the hospital, works, and most importantly, works well for the patients? So Marcia, thank you so much for being on GEMcast, and I look forward to interacting with you in the future.
Thanks for having me, Christina.
Thank you for listening to this episode of GEMcast. You can connect with me on Twitter with the handle @GEMPodcast. You can also navigate over to gedcollaborative.com for more resources on the care of older patients.